So on behalf of the International Contrast Ultrasound Society, or ICUS, we extend to you a warm welcome to all the participants in today's webinar. And I'd like to give special thanks to my esteemed faculty, and thanks also to our friends at Northwest Imaging Forums, the exclusive CME provider for ICUS. And please visit the ICUS website, as you can see on the screen, and you can register for more ICUS webinars and conveniently earn free CME from your desktop or free ICUS mobile app, ICUS Connect. And don't forget to check our website to learn about new payment codes that now double the reimbursement for all non-cardiac CEUS in the USA, a result that ICUS strongly advocated for. And we are thrilled with all of the advances in CEUS and hope that you will enjoy today's program. So what is ICUS? ICUS is the only global professional society that is solely focused on CEUS. We now have members in 85 countries and continue to grow. These members include physicians, sonographers, nurses, scientists, industry, and even patients. They represent radiology, cardiology, hepatology, vascular diseases, GI medicine, and many more. Our why, CEUS is an essential part of modern ultrasound labs around the world, and CEUS perfectly aligns with global health policy goals. It emphasizes safety and reliability. It is equivalent or superior to MR and CT scan in some instances. It's used with no ionizing radiation, no nephrotoxicity, and no risk of brain deposits. It's performed at low cost, widely available, and provides a versatile imaging technique. It frequently reduces expensive downstream testing and overall costs, and real-time diagnosis at point of care may reduce time in hospital, speed the time to diagnosis and therapy, and improve workflow. So we believe ICUS is at the forefront of CEUS education, advocacy, and strategic communication. Now, ICUS never charges fees, and we'd like to join everybody to join and have free membership. We have a free website, ICUS, which you can see at www.icus/society.org. We have a free mobile app called ICUS Connect, available on both Apple and Android devices, and we have free CEUS news monitors bi-weekly, which keep you up to date with all of the CEUS information. We offer free webinars, at least one per month, and they are watched with free CME. And this is choice of AMA Category 1 or SDMS credits. Recently, we've offered IV training and certification for echo and general imaging sonographers, and we feel that this very large step that we've taken to support the sonography side of contrast-enhanced ultrasound will benefit us greatly in the future. We invite you to explore the ICUS website, and this is the most comprehensive suite of CEUS resources that are available today. The sonographer training resource is also available with links to labeled products, webinars, reference materials, and this was developed by the Joint Task Force of AIUM, RDMS, ASE, ICUS, IAC, and SDMS, with updates pending. Our CEUS News Monitor, as I said, is sent bi-weekly, and this really includes the bubble news and many other things that we pick up that are of value to our audience. And we can download for free our app called ICUS Connect. And as I've mentioned, this is for Apple or Android devices. And we'd like you to join us in conversation on Instagram and on Facebook, where there are many interesting cases presented and changed regularly. And I'd like to make you aware, save the date for the 40th anniversary of the International Bubble Conference. And this is obviously in October of 2026 in Chicago, as usual. And of course, I'd like to you to join us in thanking our sponsors, the distinguished leaders of the ultrasound community, including our diamond and gold sponsors representing pharma and industry. Silver are our industry supporters, and our bronze, very important supporters, including Denton's, Fat Roman Studios, and Northwest Imaging Forums. So the first presentation this morning is made by my lead sonographer and very valuable collaborator, and Christina Merrill. And so she's going to speak to us on bowel contrast ultrasound, ultrasound techniques, and exam performance. Christine.
Thank you, Dr. Wilson. So as a sonographer, my presentation is focused on technique and exam performance, and then, of course, contrast-enhanced ultrasound. But in order to understand what we're looking at when we do a contrast-enhanced ultrasound, it's important to understand the grayscale features and how we document them. So let's get started. And I have no disclosures. So our objectives. Number 1, we'll talk about the introduction. Number 2, we'll talk about considerations, the patient and the machine. Number 3, we'll talk about grayscale ultrasound of the bowel, the routine, and then of course number 4, we'll put it all together and we'll talk about the technique and the role of contrast-enhanced ultrasounds. So ultrasound of the bowel, what are the advantages? It's a real-time dynamic scan, it's quick, it's safe, there's no ionizing radiation. We see the bowel and the walls in high resolution. And of course, there's a strong patient preference. When the patients come to our department, as one of the sonographers says here, you're already a winner because of all the tests that they've had done, including CT and colonoscopy, where they don't have to do the scope prep. The disadvantages and the myths of ultrasound of the bowel, well, that it's operator dependent. There's a learning curve. It's limited by gas and body habitus, and a very old myth that we've often heard frequently is that ultrasound can't see the bowel. But tips of the trade, not only can we see the bowel on ultrasound, we are good at it, and we're going to show you why and how. So the situation in bowel scanning. You can do a bowel ultrasound on any machine using any transducer, but regrettably, many do scans on old machines, outdated transducers, and machine age and software are critical, and they're not universally addressed. So we need a high-end machine, state-of-the-art CEUS software, elastography, excellent probe selection, and trained and educated operators. Our preliminary considerations include the patient, so it's optimal to have the patient fasting for 4 to 6 hours prior to the scan, and the patient must not have a colonoscopy prep, as this fills the bowel with fluid and makes it harder to see. And the patient often starts, as you see in the image here, in a supine position, but be prepared to roll them if necessary. Also, too, you can see in this image, you want your arm resting in a comfortable position, as there's sustained holding and pressure when you do the exam. The machine, most high-end ultrasound equipment comes with everything necessary to perform a bowel exam, probes, software, and note that CEUS software is likely a software add-on or upgrade, and this is important to remember that not all probes on all machines are contrast capable, so it's important to note on purchase. The probes that we use include the curvilinear standard high-frequency probe, curvilinear standard and high-frequency probe. This is for the first survey of the bowel, from rectum to cecum and small bowel, and identification of abnormal segments and their anatomical localization. Of course, we also use high-frequency linear transducers or linear probe, and that includes the endovaginal probe, that give us a more detailed evaluation of the bowel, and we get better detection of mural and mesenteric vascularity. So we're going to show you an example of what happens with different probe selections. So on the left-hand side of the screen here, you see a loop of bowel in cross-section. It's a lower resolution, but you get a better overall picture of the surrounding tissues. And this is the standard curvilinear. On the right-hand side of the screen, you can see that this is a higher resolution. You can really start to see the bowel walls here. And most bowel scans will be optimized on a high-frequency curvilinear transducer, 5 to 10 megahertz. Tips of the trade: when you need to see the bowel wall definition, move to the highest frequency probe possible. So presets, we often get asked this, how do I determine my presets? So here we have the same image with two different gain settings. So this is an ilio loop on the top, and it's the same ilio loop on the bottom. So we've taken a grayscale map with high gains and low contrast in the sagittal plane here, and you can see how the image looks washed out. And then another grayscale map too with lower gains and high contrast. And you can see how the bowel walls start to pop. You can delineate them, and you can see quite well even the other structures around the bowel. Tips of the trade. If the machine is not optimized for bowel, start with a high contrast preset, like a carotid setting. Change the grayscale maps to have more contrast. Also to consider your dynamic range. So here we have two separate images. The only adjustment is a change in dynamic range. So on the left-hand side, we've got a high dynamic range, and you can see how the image looks flat, gray, and washed out. It's a transverse section of a loop of bowel. And then on the right-hand side, we have the exact same transverse image of the loop of bowel. And you can see how you can see the wall layers, the differences in echogenicity between the wall layers really pop out, and even the peritoneum around them. So tips of the trade. Bowel imaging has many low-level shades of gray. To optimize them, you need high contrast, and we want to consider some machines have edge enhancement. That we find this has also helped in some situations. So bowel wall layers. So the bowel wall has 5 layers, and the ultrasound appearance has alternating echogenicity. So you have the serosa. So we have a graphic on the top, and we have the same images in ultrasound on the bottom. So you have the serosal surface, which is the outermost layer of bowel, and it's echogenic. You have the muscularis, which on the ultrasound appears hypoechoic, and in our graphic it appears blue. You have the submucosa, which on ultrasound appears echogenic, and on our graphic it appears yellow. You have the deep muscular mucosa, which appears dark on our ultrasound image, and then blue on our graphic. And then you have the mucosal layer, most inner layer of the bowel, which is echogenic on our ultrasound image. And on our graphic, you can see it's just pointing to the most inner layer before the lumen. So tips of the trade. Connective tissue layers on bowel are often hyperechoic, and muscle layers on bowel are hypoechoic. So ultrasound protocol, it's important to talk about what we do when we scan. So you start with the colon. It forms a picture frame around the abdomen and has fixed points. So you can see here the probe is moving, starting from the rectum, and the GI doctors often like to follow the tract from the rectum back to the ascending colon. However, we as sonographers and scanners can often follow it back from the terminal ileum to the rectum, as long as you scan it in consistent segments. Either way will work. So terminal ileum, you want to identify the ileocecal valve, small bowel loops arising from the ascending colon, and the small bowel you want to scan with a sweeping motion, and then you want to include the stomach and the duodenum. So let's have a look at what that looks like. Remember, we evaluate in segments. We want to interrogate the bowel in the axial plane and the long axis, and you want to use graded compression, which is a consistent, firm pressure to help move out the gas. So the sigmoid colon typically lies obliquely between the pelvis and the left iliac fossa. You use a 5 to 6 megahertz probe for deep pelvic portion, and you can switch to a higher frequency curvilinear for more anterior segment. And it's a common site for diverticular disease. So in our sagittal image, you can see the bladder here, and then you can see the sigmoid colon coursing from above down below the bladder. And then in our axial image, you can see those same bowel wall layers, and you can see it quite nicely over top of the iliac vessels. Our next segment is the descending colon, typically the most left lateral bowel structure, medial only to the abdominal wall, and it's also a common site for diverticular disease. Colon can have a spectrum of appearances. So you can see on the top, this is a transverse loop of descending colon with the abdominal wall. So it's the first loop of bowel over from the abdominal wall. You can see the wall layers. You don't see the back of the colon because the gas is still within it. In the sagittal picture, you can see this compartmentalization of the colonic haustra. And then on the bottom images, you can see the same piece of colon, this time with less stool. So you can see it in cross section, and you can see the wall layers nicely in sagittal section. So as we move on to our segments, we're going to go to the transverse colon. Now, transverse colon can be in a variable position. It lies transversely across the abdomen, and it may travel straight across or below the level of the stomach, or it can even drape to the level of the umbilicus or lower. And you can see this grayscale loop of bowel in transverse, nice piece of colon there, and then you can see it in sagittal as well. The ascending colon, it's typically the most right lateral structure, medial only to the abdominal wall, and an axial view may appear wider or more bulbous than other parts of the colon, but haustrations can still be visible. And it ends in the cecum in the right lower quadrant. So you can see here on the picture on the left-hand side, a transverse view of the ascending colon. And often this is the case, that it's quite filled with stool. Our sagittal plane, we can only see the top of the level of the ascending colon, and we don't see the back wall layer. But we find if we orientate or angle around the gas in the colon, we can see structures around it quite well. So we need to have a look at the terminal ileum. The origin of the terminal ileum can be in multiple planes. So it can come off the level of the cecum, can come off posterior, retrocecal, anterior. So you'll find yourself moving your probe position or orientation when you try to find the terminal ileum. Tips of the trade, it may present at multiple angles, including retrocecal, so you can have many and varying probe orientations. So it's the most distal segment of small bowel. It's the most common disease site in Crohn's patients, and it often arises medially from the cecum. You image the change in caliber of the bowel, and it will not separate from the large bowel with pressure. So you can see on our sagittal image here, we have a piece of small bowel or terminal ileum, which moves into sort of our gas-filled large colon. And if you put pressure on this bowel, they would not separate. So once you see the change in caliber of this bowel, then you know you're at the terminal ileum. And then here we have a cross-section of our smooth-walled terminal ileum. You can see it at the level of the CEUS muscle, and then you can see the anterior tissues above. So normal small bowel, when we do our flank sweeps, they're variable position. You can often see peristalsis. So on our left image here, we have a transverse loop, smooth walled terminal ileum. You can actually see the appendix beside it. This is one of the benefits of grayscale ultrasound of the bowels, that we can see it live and we can see it well. And the next picture we have is the jejunum. So in the jejunum, you can see it's peristalsing, so it's often moving, and you can see a feathered-like appearance, which is the valvulae conventis. The appendix, this is always a challenge for many sonographers. It's blind-ended, arises from the cecum near the ileocecal valve and terminal ileum. It has a variable position, as we know. Axial diameter is used as a standard for diagnosis. And how do we find it? We often find it with consistent compression. So you can see the same bowel wall layering here in this normal appendix. You can see the tip of the appendix, and you can see the appendix in axial as well. And we use a firm but consistent pressure to move all the other bowel out of the way. And then we can usually see, most patients see the appendix quite nicely. It's really important too to talk a little bit about color velocity and our settings. So the bowel has very low velocity flow. So velocity settings at low speeds will not be in the standard settings on most equipment. So you can see here on our first image, we've got our velocity at 18.5 centimeters per second. So when we put the color box on the bowel, we see absolutely no color flow in that bowel. So on the second image, we have the exact same loop of bowel, and we've taken our color velocity scale down to 7.7 centimeters per second. And now you can see that in the muscular wall or muscular layers of the bowel wall, there's avid color Doppler imaging. So sometimes adjusting the color Doppler on most machines takes a little bit of work, but it's worth it because it gives you a lot more information. Now we're going to look at bowel. Now that we've looked at some grayscale images, how to document it, we're going to look at bowel with the inclusion of contrast ultrasound in IBD. Specifically, we're going to look at the technique. So sonographic evaluation of IBD and its imaging features look at two things. They look at extent and activity. So we want to look at how much disease is there, the length of disease involvement, localization, where is it? Crohn's disease often has skip areas. We're going to look at the thickness of the bowel wall, inflammatory fat, and lymphadenopathy. And for activity, bowel wall thickness most accurately reflects activity, and the amount of blood flow is directly related to the amount of inflammation. And this is assessed by color Doppler and contrast enhanced ultrasound. So we're going to look today about how do you image or document an effective loop of bowel. So we have a loop of bowel here, and we want to make sure that we take pictures of it in cross section on the left-hand side and then in sagittal section on the right-hand side. So you can see our loop of bowel here. You can see our wall layers of alternating echogenicity. And then around the outside of the bowel, you can see this bright hyperechoic zone. So this is actually an inflamed loop of bowel in a patient with Crohn's disease, and this is inflammatory fat. So normally in a normal piece of bowel, you would see other bowel wall loops adjacent or touching it. But here you can see this big white zone. So it's really important to make sure we document the inflammatory fat around the bowel. So not only the bowel wall, but what's happening around it. You want to look at the length and the location of the disease. You want to document whether it's in the right lower quadrant, right upper quadrant, or left upper quadrant, left lower quadrant. And then you want to document the length or measure the actual length of the disease, and then inflammatory fat around it again in a sagittal plane. So bowel wall thickness is really important because it's the biggest indicator of disease severity. So it's important to accurately place your calipers for measurement. So you want to place one caliper on the mucosal lining or the most inner surface of the bowel wall, and then you want to place another caliper on the serosal surface. And you want to measure the thickness of the bowel wall in the largest, or you want to measure the bowel wall thickness in the widest or the largest portion. Often the cross-sectional imaging is the best place to do this. So just to review, what do we want to document? Bowel wall thickness, color Doppler imaging, inflammatory fat, and then of course nodes or other peritoneal findings. Dr. Medellin is going to talk about the significance of this in her presentation. Contrast of the bowel. So let's look at a case. So here we have a piece of bowel in dynamic roll time. You can see the cross section, you can see inflammatory fat around it, you'll see the bowel wall layers. And of course, we're going to do our standard image acquisition, which is the top frame here. You can see a sagittal loop of bowel with thickened wall layers and inflammatory fat. And then in the transverse section, you can see the cross section of the bowel wall, same loop of bowel and inflammatory fat. On the bottom, we've put color Doppler imaging on this bowel in sagittal and transverse as well. So tips of the trade: the sagittal and transverse scan planes are orientated to the bowel and not to the patient. So how do we add contrast ultrasound to this? And what happens when we do? So contrast ultrasound detects microvascular flow, not seen on Doppler. It's not angle dependent, gives a real-time assessment of perfusion, and the next talks will address the use of contrast ultrasound in IBD, but we're going to look strictly at technique today. So here we have a dual screen display. This is a contrast ultrasound image as we inject the contrast. On the right-hand side, you can see our low MI grayscale image. And on the left-hand side, we have a microbubble only image, and you can see avid enhancement of those bowel walls. You want to make sure you keep the following parameters the same for all patients, including the gains and the mechanical index and the contrast dose. And you want to obtain a continuous acquisition for 2 minutes. Tips of the trade: when you position the grayscale ultrasound in the sagittal plane, this allows the patient to breathe quietly and your target area remains in the field of view. So subjective analysis of a contrast scan of the bowel is a visual experience-based interpretation. Signal intensity, or CEUS, is a reflection of the volume of bubbles, which is directly related to blood flow and blood flow volume. So subjectively, what do we know? Appearance or increased enhancement of the bowel wall suggests increased blood flow. Objective analysis of the contrast scan of the bowel gives us measurable parameters and creates a repeatable numeric value, which provides a greater reliability. So tips of the trade: measurable data can be derived from time intensity curves. So we create a time intensity curve, an imaging method that can assess tissue perfusion and can map blood flow, creating a graphical display. So we put our region of interest on the bowel wall here. We acquire a 2-minute clip. We measure the pixel intensity in the region of interest over time. And you can see here, I'll let the clip run. So we want to remember to standardize the dose, the gains, and the mechanical index. So contrast enhanced ultrasound, the wash-in phase is the rapid rise in signal as the contrast arrives. The peak enhancement is the maximum intensity reached, and the washout phase is the gradual decline in signal as the contrast dissipates. Tissue metrics include time of arrival, time to peak, area under the curve, and peak enhancement. And the clinical relevance: increased volume of bubbles reflects neoangiogenesis of blood vessels seen clinically in 2 situations, inflammation and neoplasia. And the impact is a high peak intensity and area under the curve. The time enhancement differs in the following circumstances: blood flow in the bowel wall, and increased time to peak and time of arrival. So after examining a bit of technique, we will now move on to the application of ultrasound with special attention of contrast ultrasound in bowel imaging with Dr. Medellin. Thank you.
Thank you so much, Christine. That was great. Now we'll introduce our next speaker, Alexandra Medellin, MD, FRC, PC, Body Imaging Radiologist, Department of Radiology, University of Calgary, Calgary, Alberta, Canada. Dr. Medellin.
Thank you very much. Good morning or good afternoon for some people. Thank you for the invitation to CEUS for this amazing presentation. And thank you, Christine, for that great presentation. I will share with you today how contrast enhanced ultrasound is revolutionizing IBD evaluation. I don't have any pertinent disclosures. We will cover 5 important key areas: an overview of IBD. We touch on IBD assessment with a special focus on imaging. We'll describe ultrasound and contrast enhanced ultrasound evaluation, performance and advantages, and we'll review some key takeaway points. Let's start with what's inflammatory bowel disease. This is a group of chronic relapsing disorders that present in young patients, but can also have a bimodal distribution. It is characterized by alternate episodes of active inflammation and remission, and chronic inflammation can create significant bowel damage and complications. Clinical assessment is challenging, and disease activity does not correlate with symptoms. Therefore, we heavily rely in imaging. IBD will include Crohn's disease and ulcerative colitis. So Crohn's disease overall can affect any part of the GI tract. It has an skip distribution with a transmural inflammation and can present with inflammation, inflammatory changes, structuring, or penetrating behavior. The treatment of IBD may have a high potential for significant complications, and we know that patients with Crohn's disease have high surgical rates. On the other hand, ulcerative colitis affects the colon only, and it has continuous distribution, and is characterized predominantly by mucosal inflammation. Its extent may localize to the rectum or could affect the left colon or the entire colon. So globally, we know that IBD affects approximately 250 patients per 100,000. It has a high prevalence in Europe and highest incident or new cases in the Oceania, but also have regional incident trends, especially in North America, with increased numbers that are especially in the pediatric population. Therefore, it necessitates early detection and intervention to avoid any complications. Now let's briefly talk about the pathophysiology of IBD. This involves a complex interplay of genetic susceptibilities, environmental triggers, microbiome dysbiosis, and immune dysregulation. In simple words, it is believed that these patients have a compromised intestinal barrier that allows bacteria and antigens to cross the mucosa, and this will trigger an abnormal immune response, which is characterized by the excessive production of pro-inflammatory cytokines that perpetuate inflammatory response and cause this tissue damage and disruption of the normal gut function. This creates these findings seen in imaging and endoscopy, such as humoral inflammation, granulomas, fistulas, and structuring. We all have to remember that inflammation also causes increased vascularization with new blood vessel formation, leaking capillaries, tissue inflammation, and ulceration. These inflammatory changes are what we want to detect early to change patients' outcomes. The goal in the evaluation of AD is the detection of active inflammation. This requires a modality that will be sensitive for the detection of inflammatory changes within the bowel wall and mesentery, detect complications as well. In addition, it should be safe, well-tolerated modality, and that can be used frequently. It is also important to have objective measurements of inflammation that can be followed over time, especially during the use of different therapeutic regimens. Currently, patients are assessed symptomatically every 3 to 6 months, but we know that symptoms do not correlate well with disease activity. Endoscopy is recommended annually or as needed. However, endoscopy also has some limitations, especially because it only evaluates the mucosa changes. And as you remember, I mentioned that Crohn's disease affects the whole entire wall. So this will be very difficult to foresee for endoscopic changes. Sometimes endoscopy cannot reach the proximal small bowel loops, given that there is a stricture or a failure to intubate, and definitely cannot assess the left upper quadrant small bowel loops. MR enterography and MR and CT enterography is suggested to be used every 1 to 2 years or as indicated. However, these modalities are costly, there are limitations for accessibility, and in case of CT, ionizing radiation is undesirable as a frequent exam. Therefore, in recent years, ultrasound, including contrast-enhanced ultrasounds, have been proposed as an excellent modality for evaluation of these patients. The advantages are that it is safe, accurate, readily available, and can be performed frequently if needed with non-risk for ionizing radiation. It allows for the dynamic assessment important for evaluation of bowel peristalsis and any complications, and can be used for at the time of diagnosis, surveillance, and in acute presentations. Also, we use it in patients for assessment of treatment. But now let's see what is the diagnosis performance of CEUS versus conventional imaging and other techniques. This recent publication in 2024 shows that CEUS have a higher diagnostic accuracy for the detection of active inflammation when compared to conventional grayscale ultrasound, and also has a comparable accuracy with CT enterography. Therefore, we are advocating that contrast-enhanced ultrasound should be considered as an important image modality to evaluate for these patients in IBD. Let's look at how do we do and grade our assessment in our clinic. In our institution, we use the ultrasound global assessment. This will use different parameters, including the wall thickness, the color Doppler imaging, and the inflammatory fat, as nicely demonstrated by Christine earlier. And depending on the degree of each parameter, we can objectively and subjectively identify and assess the degree of blood flow and as a reflection of inflammation. We can grade the disease as inactive, mild, moderate, or severe, as you see in the cases in this graphic. The higher the inflammatory or wall thickness, the higher and the severity of the disease. Similarly, with the color Doppler, you see the color increases as the severity or the inflammation is increasing. With inflammatory fat, the degree of inflammation around the bowel also worsened with the severity. We had also incorporated the contrast enhanced ultrasound parameters with the assessment. These values will range and will be correlated with endoscopy and pathology. As you can see, I'll show you some examples, but we'll talk about how do we and what is this important than CEUS is incorporated IVD. In our publications, so we do a subjective and objective measurements of the mural perfusion at the capillary level. We put a region of interest and we'll create this time intensity curve. CEUS will show in real time the mural enhancement and the decline of the contrast. The time intensity curve is created, which shows actual fractional blood volume by the determination of the peak enhancement and the area under the curve. The blood flow within the bowel wall by the time of peak or the slope of washing in, as well as we can have the transient time. So we have evaluated our publication, and what we're trying to correlate was the degree of peak enhancement and the area under the curve in relation to the endoscopic changes and the pathology. And as you can see, on the top, we have a subjective assessment where a normal bowel will have lower vascularity, and you compare to the other extreme with severe disease showing significant transmural enhancement. And we also see the mesenteric vessels, which are engorged, suggesting a severe active inflammation. We can correlate and we interpret these values. And as you can see, the active or normal bowel will have low levels of peak enhancement, while in the other hand, the severe inflammatory changes will have very high numbers, over 23 dB. So how, let's put this in practical context. So we have this patient who comes to our clinic who is 35-year-old male, recently diagnosed with Crohn's disease. He comes to our clinic for his assessment of disease activity and extent. We perform our normal survey, as Christine showed us earlier, and we have identified an abnormal loop of bowel, long segment with mural thickening that is maximum of 9 millimeters. And with our color Doppler signal, we can see mural hypervascularity, which is very significant. So we know with these parameters that this patient has severe active disease. We perform our contrast enhanced ultrasound, with also confirms some transmural enhancement of the bowel wall, with peak enhancement really high of 27 dBs and a large area under the curve. So we know that this patient has concordant findings on grayscale and contrast enhanced ultrasound consistent with severe active disease. Let's look at another case. This 34-year-old female, also newly diagnosed with Crohn's disease, comes to our department for disease activity assessment. On this patient, we have identified a short segment of abnormal small bowel loop, which shows a stricture segment, proximal dilatation of the bowel, and some evidence of mechanical bowel obstruction. The bowel wall is really thick, measuring 7 millimeters. But when we put our color Doppler, this is actually a picture of the power Doppler with optimization, we don't detect any flow. So definitely we can see that there's a discrepancy of what we have shown you so far. There's a discrepancy between what we see in the wall thickness versus the detection of color Doppler imaging. So at this time, we start thinking, is this patient has inactive disease, or patient has active disease but poor detection on color Doppler image? So this is activity for us at this point is indeterminate. So let's check why this could happen. So we know that in determinant activity, we know that color Doppler imaging has lower sensitivity. It only have a sensitivity of 87% and a specificity of 69. And CDI only detects large blood vessels with fast-moving flow, and therefore has some limitations, especially because can or has some difficulty detecting low-velocity blood flow. It is difficult to detect the small vessels or the capillary perfusion on the bowel wall. And when the patients have deep abnormal segments or segments within the pelvis that cannot be reached by an endovaginal ultrasound, the color Doppler, it will be difficult to detect. Also in patients with large body habitus, color Doppler is difficult to assess as well. Contrast enhanced ultrasound, in the other hand, has a higher sensitivity than CDI with a sensitivity between 88 to 90, a specificity or 92, and have multiple advantages. We can look real time the microvascular tissue perfusion at the capillary level, can help us overcome some patient's factors, can look at the enhancement pattern of the bowel wall, either evaluation of the mucosa, all the layers, or if the tissue or the bowel wall is transmural. We can also create, as we have talked so far, then we can create those times intensity curves for an objective quantification. So let's go back to our case number 2, where we have this patient with a stricture segment, abnormal bowel thickening, but no color Doppler detection. We perform our contrast enhanced ultrasound. As you can see in the bottom left corner, they have the segment of the abnormal bowel, which is enhancement in a transmural pattern. And the time intensity curve shows that the values are 18 dB. For us, this will correlate with a moderate active disease, and therefore contrast enhanced ultrasound can resolve these indeterminate cases. And now we can tell that this patient has a moderate active inflammation, and the patient will be treated accordingly. Other important use of contrast enhanced ultrasounds is in the therapeutic response. So as we talk all about inflammation, we know that we have to detect these inflammatory changes early. So identification of the flow and the vascular changes in therapeutic response is one of the most important goals. And this have to be important to have objective measures that we can follow over time to see if the patient is improving or there is no really real change with the new therapy. So let's look at this case of a 50-year-old male who has Crohn's disease and is initially assessed with ultrasound prior initiation of any therapy. The patient comes to our clinic. We detect abnormal segment of a small bowel in the right lower quadrant. This represents the terminal ileum with abnormal wall thickening of 8 millimeters, and there is severe mural flow. So we know that this patient has severe disease. We perform our contrast enhanced ultrasound. There's nicely example of a transmural hyperenhancement of the bowel, and our parameters on quantification are really high as well, with 24 dB peak enhancement and a large area under the curve. So we know this patient has severe active disease. He will be treated, and this patient actually got biologics. He come back 6 months later for a reassessment of his therapeutic response. And we assess our grayscale images. And you can see there is not really a significant change between the grayscale in the initial exam and 6 months later after therapy. We still see persistent mural thickening and severe blood flow within the wall. However, when we perform our contrast enhanced ultrasound, we show that there is some improvement in the quantification parameters. Peak enhancement has decreased from 24 to 17, and our area under the curve is also lower. This suggests to us that there is an early therapeutic response and the patient will continue with therapy. So let's see, why is this happening? How do we explain these changes? Well, we know that some patients will have some persistent wall thickening. And sometimes this wall thickening will take longer time to change, especially because in patients with Crohn's disease will have this mucosa hypertrophy. In addition, color Doppler imaging, as I mentioned before, shows a large blood vessels with fast-moving flow, and therefore, when we see the early therapy changes, we see first time that the perfusion of the capillary perfusion is the first one which changes after treatment. And this can be very subtle and difficult to detect with color Doppler imaging. On the other hand, we know that contrast-enhanced ultrasound is more sensitive for the detection of blood flow at the perfusion and capillary level, and therefore this allowed us early detection and determination of vascular changes that appear first. And we also have the advantage of do some quantification parameters which can be, which changes can be more obvious, objectively graded, and follow over time. So when we use contrast-enhanced ultrasound, we think that CEUS improves our disease activity assessment. We can subjectively observe the mural changes and the mural perfusion at real time. We can evaluate also for mesenteric vascularity with engorgement of the vasa recta, which are very nicely shown in the picture below with the COM sign that we can see also in CT. And we can do this objective measurements with the creation of the time intensity curves with the peak enhancement, an area under the curve. We can grade the disease between mild, moderate, and severe and see the changes over time. So finally, my key points, and I want you to remember when you back in practice, that the CEUS have high contribution and is highly important in evaluation of bowel pathology in IBD. First, because our activity detection and grading is the most important factor, important when we determine disease activity and in follow-up the therapeutic response. It has a high diagnostic accuracy for detection of active inflammation, allows for objective quantification parameters, grading inflammatory activity, excellent detection of microvascular flow as a complement to CDI, and it clarified those indeterminate cases. We use it all the time for IBD treatment response for detection of early changes at the microcirculatory level, and we use those objective quantification parameters to follow the patient over time. So thank you very much for your attention.
Thank you so much, Dr. Medlin. That was a great talk. We are now going to reintroduce our moderator who started us off, Dr. Wilson. And as she gets the screen up for her talk, just want to remind everybody to find the Q&A button on your screen's lower menu bar. So after Dr. Wilson's talk, we will have a live Q&A with our faculty.
Thank you very much. So thank you, Alex and Kristen, for a wonderful introduction to this topic. So my presentation today I've entitled CEUS of the Bowel, Inflammatory and Neoplastic Angiogenesis. And angiogenesis, of course, is the important factor for contrast-enhanced ultrasound. So I have disclosures, I have research support, both pharmaceutical and equipment, and I'd also like to make the comment that the use of microbubble contrast agent for imaging of the bowel is off-label, and off-label, of course, is not bad, just off-label, and we do literally thousands of these exams every year. So let's start off by looking at the complications that we see in inflammatory bowel disease. So the three major phenotypes that we see in Crohn's disease are inflammatory, which has been nicely covered already, and then stricturing and penetrating complications. And so we will show considerable material on these topics. So strictures in inflammatory bowel disease are very important, as Crohn's disease, as already mentioned, has a very high surgical rate. And the most common indication for surgery is the presence of stricture and its complications. And of course, the highest association is with incomplete mechanical bowel obstruction. So what is the clinical motivation for imaging these patients that we know have strictures? Well, we want to know the presence of the stricture and what it's doing, but very most important is what is the type of the stricture. So when we see a slide such as this, where we're looking at a loop of terminal ileum in long axis, we can see that there's a length with the luminal surfaces in apposition. This is the stricture, the prestenotic dilatation, and the clinicians are wondering, is this an inflammatory stricture which would be treatable with medical therapy, or is this a chronic stricture which invariably has to be treated with surgical resection? So let's look at a patient. So here we can see that grayscale is where we always start, and we look at still images and the dynamic real time, which is of critical importance here. So we can see on the left image that we have prestenotic dilated bowel on the right side, and then the bowel is squirting through a stricture which has a black appearance with complete tight luminal apposition, such that only a squirt of material goes through with each peristaltic wave. So this allows us to see that this is a severe stricture. And then the right image is looking at the bowel that's proximal to the stricture. And of course, this bowel is where we measure the caliper to suggest the severity of the stricture. But here we can also see that in addition to the dilatation of the bowel with the excess fluid content, that we also have excess and severe dysfunctional peristalsis with to and fro motion. So this tells us all of this just on the grayscale examination. But in addition to that, we want to add both contrast-enhanced ultrasound and shear wave elastography, the first to show us the blood flow and the second to show us the degree of stiffness of the bowel. So when we look at the measurement of the stiffness, you can see that we've placed a region of interest on the right-hand axial image within the bowel wall, and we measure the stiffness that is reflected in the velocity of the sound wave coming back. So 2.8 meters per second, if we consider 2 meters per second as the divider between normal and cirrhotic liver, you can imagine how stiff that is. And this is stiffer even than that liver would be, that would be cirrhotic. So 2.8 is in the stiff range, and this patient has got what we would suggest as abnormally stiff bowel. And then when we look with contrast-enhanced ultrasound, which was beautifully covered in both of the former presentations, this peak enhancement is only 16 decibels, which is relatively low level of inflammatory activity. So low CEUS quantification and stiff bowel suggests a chronic stricture. And this patient has gone to the operating room and had this bowel resected. So when we look at the chronic stricture, which is on the right, and we're comparing it with a normal loop of bowel on the left, we can see that the star is marking the muscularis mucosa, the superficial layer, and we can see that in the normal bowel, this is very, very thin. We can just barely see this thin layer of pink representing the muscularis mucosa. And you can see that there's volume expansion of this muscularis mucosa in the chronic stricture. And then when we look at the muscularis propria, you can see again tremendous volume expansion of the muscular layers. And we have found this throughout all of the pathology patients that we have had the opportunity to scan. So muscular expansion, you can imagine this is like an Indian rubber ball. And so this is why this bowel is stiff when we measure it with elastography. And so this is taken from one of our own publications, which received a certificate of merit in 2020 at the RSNA, and it looks at our own interpretation of the performance of the elastography. And you can see that we do both a quality and a stiffness display. And this is our own personal experience that we regard the bowel that's more than 2 meters per second as stiff. And of course, we get tremendously stiffer bowel than what we have as our threshold, and that bowel that's down less than 1 meter per second is within the normal range. So let's just look at another patient, a 27-year-old male who surprisingly has no symptoms. However, he clearly has a stricture with prestenotic dilatation, loss of wall layers, thickening luminal apposition, and surrounding inflammatory fat. And when we look at this further, we can see we have a quality and a stiffness reading. The reading here, 2.5 meters per second, again, stiff bowel. And this is a chronic stricture, which was addressed with surgical attention. So an inflammatory stricture shown here, you can see the wall layers are still preserved. We see on the middle long axis view, the dilated segment on the right and the stricture more to the left of the image. Again, the peak shear wave elastography is only less than 1 meter per second. So this is in the very soft range. And when we look at this patient's CEUS, we see that the value is 28 decibels. So this is an inflamed loop of bowel with low stiffness. This patient was treated with biologic therapy. 6 months later, when we do a follow-up scan, the patient has reduced obstructive symptoms and an improved ultrasound global assessment score, as was described beautifully by Alexandra in the former talk. So stricture characterizations, we've noticed that chronic strictures have a tendency to low inflammatory activity and stiff bowel, whereas inflammatory strictures have a tendency to high inflammation and soft bowel. So in other words, they're inversely related. And so we published this in Inflammatory Disease in 2017. And Dr. Liu, Kathy Liu, who was the first author, she was our fellow at that time, has gone on to become one of the world leading investigators on strictures on ultrasound. And we'll end with this example of a patient with an endovaginal scan, which shows a stricture that was beautifully seen here, but not appreciated on the transabdominal scan, as the stricture is located deep in the pelvis. So we have a very low threshold for endovaginal sonography. And you can see on the top images, the grayscale image in long axis and axial, showing the strictured segment, the prestenotic dilatation, and the color Doppler reflecting the inflammation of this inflammatory stricture. So let's go from that topic to other topics. So contrast-enhanced ultrasound provides resolution of masses that we identify on bowel ultrasound. So tumors and inflammation both stimulate new blood vessels and frequently produce masses that we can see on our grayscale scans. And so when we think of inflammatory things, we're asking ourselves, are we looking at an abscess or just phlegmonous change? And when we consider neoplastic involvement, we want to know, is it a tumor or just a poo ball? And if we decide that it's a tumor, we want to determine if we think it's malignant or we think it's benign. So how do we address these? Well, CEUS resolves inflammatory masses that are not differentiated on grayscale. So abscess and phlegmon are not differentiated when we start out with our scan. And the most important fact to remember there is that both of them can appear black on grayscale, and in fact, both of them can appear to be solid. But when we do CEUS, we know that the abscess portion will be avascular, whereas the phlegmonous component will show variable vascularity, which can be very high on CEUS. So let's look at this 35-year-old female with Crohn's disease. So she had a clinical flare and had been on steroids for 1 month. And she comes back for a surveillance evaluation. And we can see when we look at her that the bowel is really surrounded by these very solid-looking mass lesions. And so are these solid masses? And if so, what are they? Well, we want to do CEUS to resolve this. So when we do our CEUS scan, we can see that the solid-looking mass is in fact completely avascular, and it represents an abscess. And the bowel, you can see, shows enhancement of the mucosa. And so this patient has developed on her month on steroid therapy an intraloop abscess. And this was treated promptly in our interventional department with aspiration of well over 1 liter of pus from this intraloop abscess. 2 further patients who we see looking at their right lower quadrant, we can see abnormal bowel on both and surrounding very black material that looks to be fluid. Now, when we do contrast-enhanced ultrasound on the patient on the top, we can see that everything is enhancing, so that this represents undoubtedly phlegmonous change with no liquefaction, whereas the patient on the bottom panel, we can see that the black areas on the grayscale scan correspond with avascular areas, and that these represent pockets of pus. So this is an excellent use for ultrasound. Now, what about this patient? A transperineal scan for a patient with known fistulous disease related to Crohn's disease. And so when we do this scan, you can see sweeping from the top to the bottom that we can see abnormality related to the arrows in the perianal space and the anal canal. And our still image on the right-hand side, there's the anal canal, fistulous out the posterior aspect into this large perianal surrounding mass. And so then we go on to contrast-enhanced ultrasound, looking at that same area. So the anal canal virtually completely enhances, whereas the perianal soft tissue mass is got pockets that are completely avascular. So this represents an avascular perianal abscess, well characterized again on CEUS. So CEUS confirmation of abscess is an excellent component of IBD imaging. And once you start to use it, it's absolutely essential, and you will always want to have it. And it contributes also to inflammatory processes throughout the rest of the gastrointestinal tract in patients who don't have inflammatory bowel disease. So let's look at some of these. So the first is a very incredible case, a 35-year-old patient who's had cervical cancer following, then she had a missed rupture of her appendix, and she had a pelvic abscess drained. Several months after she had her pelvic abscess drained, she returned to emergency with pelvic pain. And she had CT scan, which was confusing, and went on to ultrasound. So on her CT scan, all they say on this exam is that there is no abscess. And although that is true, this is the wrong interpretation. How do we explain these loops of bowel with all these spiculated edges and all this low density material? So the patient comes for an ultrasound scan. So when we started on our transabdominal scan, we thought it was a very poor access to the region of interest. So we went to endovaginal scan. And this is a sweep which shows normal looking bowel, but evidence of soft tissue separating the loops of bowel. So when we look at these images, what is all of this gray material? It's got pointed edges as it comes to the margins. It's obviously within the peritoneal cavity. So what is this gray material? So when the bowel looks well, the low-level echoes everywhere around. The acute angle suggests it's peritoneal disease. But what is this? Is this represent pus? Does it represent some kind of tumor? Or does it represent peritonitis? So how do we know this? We can see that there are cystic areas, there are septa, there's solid tissue filling the peritoneal space, or with that appearance. And so we're going to, of course, go on to clarify this with contrast-enhanced ultrasound. So when we do an injection of microbubbles, we can see the bowel loops are quite brightly enhancing, but all of the soft tissue between the loops of bowel, seen here and seen here, they're all enhancing. So all of this soft tissue is enhancing. So what does this represent? So soft tissue is vascular. And so what this turns out to be, this is fibrinous peritonitis. Extensive soft tissue filling pelvis is vascular. And it has heavy growth of Enterococcus species and Eikenella corrodens. And this patient was treated with intravenous, a very aggressive antibiotic therapy with a positive response. So what about the appendix? This is an 18-year-old male who presents with right lower quadrant pain. The requisition to us asks, is this Crohn's disease or is this appendicitis? So when we look at this patient, we can see this cecum in front, and then behind the cecum in this retrocecal area, there's a mass lesion. There's the appendix with obvious full thickness rent in the wall of the appendix. And so when we look in cross-section, we see the cecum in front, the retrocecal appendix, and the surrounding periappendiceal soft tissue mass. So when we do a contrast of this, we can see the appendix enhancing within the center of this mass. We can see that most of the mass is enhancing and phlegmonous, but we can see readily shown on the still image that there is a pocket of pus, so a periappendiceal abscess with extensive phlegmonous change. So what about this patient, a 52-year-old Asian woman who presents with right lower quadrant pain? She had an indeterminate CT scan showing extensive inflammation in the right lower quadrant that was indeterminate. So when we look at her soft tissues, we see big inflammatory change, a lot of inflammatory fat, pockets of hypoechogenicity and hyperemia. We are suspicious here of an air-containing pocket within this phlegmon, and we finally, with great effort, identify this typical appearance for a diverticulum, a bright echogenic focus in the pericolonic space with sharp acoustic shadowing, and we know for certain that this, of course, is acute diverticulitis of a right-sided congenital diverticulum. And this, of course, is something that we've known for years has a predilection to occur in Asian women, as here. And so this patient was treated conservatively with ultimate resection of this diverticulum. And when we did soft CEUS on this patient, we see that this is largely phlegmonous change, but within there is again a pocket of avascular pus. And a recent case, a 32-year-old male with a short history of GI distress, he had a CT scan, which raised the possibility of him having IBD as evidenced by the inflammatory change in his left lower quadrant. Now, our interpretation was a little different. This is us looking at the sigmoid colon, and we can see that there's seemingly a rent in the wall of the sigmoid colon with a adjacent mass lesion. And so this is, of course, what we've thought most likely would be related not to inflammatory bowel disease, but to a perforated diverticulum. And so when we look at this, you can see that we're looking at soft tissue change, but we don't really see anything that looks to us like it would necessarily be an abscess. But when we go on to do contrast-enhanced ultrasound on this patient, we see that not only is there a pocket of pus, there's a very large pocket of pus measuring up to 6 centimeters. And this, of course, had to be treated with drainage of this collection. And now, leaving those inflammatory masses, what about tumor masses that we see? So this was a 76-year-old female with cachexia, came to us with a requisition asking, does this patient have inflammatory bowel disease? So on CT, this was not determined, but on ultrasound, you can see on grayscale, we're suspicious immediately on the sagittal and axial views that there's a soft tissue mass within the cecum. And we can confirm, actually, in this case, with color Doppler, that there is, in fact, vascularity within this mass, but it doesn't show anything like the vascularity that we can see very easily with CEUS, where we're focusing on that soft tissue from the grayscale scan, and we can confirm this cecal adenocarcinoma with ease. What about this patient? This is a patient where on the transabdominal scan, we could see a mass lesion deep in the pelvis. And so on this woman, we went to endovaginal scan, and you can see that we have fluid, some fluid in the rectum, and it outlines very beautifully a mass lesion in the rectum arising from the rectal wall. And when we add contrast-enhanced ultrasound to this scan, you can see that we very easily show again that this is a hypervascular tumor, well-defined tumor, and this is a tubulovillous tumor with areas of dysplasia. So a very, very important detection of a very large tumor, as I said, with dysplastic cells. And the feeding vessel, of course, seen very nicely on color Doppler. Now, this is a patient that was of great interest to us. This is a 44-year-old female who has Crohn's disease and came to us following exacerbation of her symptomatology in her right lower quadrant. So when we're looking at her ileum, you can see, as marked by the arrows, that there's a hypoechoic mass lesion that fills the lumen of the bowel and causes total disruption and destruction of the bowel wall layers. So this area has no continuation of the submucosal layer of the bowel wall. So we're thinking that this is a tumor. When we do our contrast ultrasound, you can see that it's hyper-enhancing, a large hyper-enhancing tumor, obviously invasive, and that was an invasive and malignant neuroendocrine tumor. And here another patient with a mass on ultrasound. She had a biopsy of a mass shown on colonoscopy, but the biopsy was negative. MR shows that there is a mass lesion within the colon with hyperenhancement, but nothing as beautifully as shown on the ultrasound, where we can see the big black mass. We can see on CEUS the hyperenhancement and then the washout. And then when we look in detail on our grayscale imaging, we can see the total destruction of the wall layers with this invasion into the perirectal soft tissues. Again, a malignant neuroendocrine tumor. And I'll end with this wonderful case. This is a quite old case, but one of my sonographers brought me this beautiful image of an appendix, and she said, I can see the layers of the appendix right to an area, and then the appendix looks black at the tip. Could I do an ultrasound? And I thought, sure, that would be a good idea. So she goes in and does this beautiful ultrasound, where when we look at an axial view, we're looking at the appendix in cross-section. And here you can see a papillary hyperenhancing nodule filling the lumen of the appendix. And then we can get this beautiful still image showing this hyperenhancing polyp in the appendix. So we call this as a hyperenhancing polypoid mass in the appendix. And we didn't ask for any confirmation because we were very confident it was there. But the clinician who owned the patient decided to do a CT scan, and he comes to me and he said, Stephanie, the CT scan shows a normal appendix. And I said, well, it's not normal. And so they took her to the operating room, and that was a malignant polypoid tumor in her appendix. And so what have we looked at this morning? We've looked at several things, but we've looked at the value of looking at dynamic real-time scanning. Here we can see a sweep to show the extent of disease, and we can see on the right-hand screen the functional aspect of looking with ultrasound, which we believe both of these are tremendous assets for us. For complications in IBD, we can see a entrovesical fistula on the left-hand side, again with ease, the air pocket or the air tract between the two surfaces well seen. And on the right, an enterocolic fistula between the terminal ileum and the sigmoid colon, where we can actually see the bubbles percolating from one loop to the other. So we think that ultrasound has got great advantages, and we've added in today, I hope, a belief that CEUS is an amazing benefit as well. So many recognized benefits of CEUS, including differentiation and diagnosis of inflammatory masses. It's excellent for tumor detection and characterization. For the patient with inflammatory bowel disease, who's often young at the time of diagnosis, facing a lifetime with chronic disease, a disease that often lacks agreement between symptoms and pathology, and where biologic therapy is now standard, we have a requirement for safe, readily available, inexpensive surveillance, and ultrasound with CEUS meets these requirements. And so it has also been shown in meta-analysis to be equivalent to CT and MR scan. So on behalf of myself and Alex and Christine, we'd like to thank the audience, and we hope that there would be some questions generated by these presentations. Thank you.
Thank you so much, Dr. Wilson. So for the Q&A aspect, I see we do have some questions there. Christine, did you want to take the lead on that?
So the first question is, are there any serious differences between DEFINITY and SonoView? And the quick answer in the chat, and Dr. Wilson and Dr. Medellin, you can confirm that, is there's no difference in the image produced with either agent. The difference is only in the application and the dose.
Agree.
And our next question It's about pediatrics and mesenteric thrombosis. And I think it's what happens when we do not see peristalsis in children with renal failure undergoing peritoneal dialysis. Maybe I could ask Dr. Wilson or Dr. Medicine, can you comment on the use of CEUS in mesenteric thrombosis?
No.
Okay.
I wish I could, but no, I really can't. And of course, I can't.
Okay. And okay, so let's move to our next question in chat. Do you use water 20 minutes before the examination to distend and better appreciate the wall thickness of the terminal ileum?
I'd like to answer that. So we don't use water, and the Italians especially have made popular using oral contrast, which is similar actually to PrEP that's used for colonoscopic examination. And we tried to use oral ingested fluid for quite a few months, and I found it not to be helpful. So we tend to go to the other extreme. We like to examine the bowel as close to possible in its resting physiologic state. And so if the patient has bowel obstruction or dysfunctional bowel, we can see that automatically. Whereas if you give a patient a fluid load or any amount of fluid, then you don't see better. And you, in fact, confuse your real-time evaluation by showing peristalsis that may not reflect anything to do with functional upset. And so we do not do it. And we, in fact, encourage patients to not have a large amount to eat or drink prior to the scan.
Thank you. And our next question. How common is the use of contrast-enhanced ultrasound in the evaluation of the bowel?
It depends where you are. If you come to our department, we do it all the time. So we routinely use it. And Alex and I have done a study that we have never published, unfortunately, but Alex alluded to it today. And so this is the difference between color Doppler and contrast enhanced ultrasound. So although a baseline examination, when compared with the results of CEUS or the additional information from CEUS, so in patients with severe active disease where they have big blood flow, big thick wall, all kinds of complications and things wrong, with and without CEUS, the opinion will be that the patient has severe disease. But in this case that Alex showed a beautiful example of this kind of acute on chronic disease, we feel as though the reproducible result we get from objective measurements on CEUS helps. So we do use it a lot. Plus, we use it for all the masses that we see and for differentiation of inflammatory masses. So we use it a lot. Now, there's no doubt that CEUS has not been universally accepted. And this may be related to the fact that many people do GI ultrasound in facilities or in environments where it's not as convenient to have a nurse and to have IVs and that a crash cart, all of the things that you need to do that. So it does depend where you are. But for us, we do really like it and we do really use it. Want to add anything, Alex?
Yeah, I just want to ask just a short comment. I just recently, doing the presentation, I did a published review of all the new articles lately. And I was really, really surprised and happy to see that now there's lots of more publications on contrast enhanced ultrasound of the bowel that is becoming, I believe, a very important part of the evaluation of the bowel. So in comparison, when we started many years ago, now it seems like it's ramping up, and I'm so happy to see that.
Oh, well, so actually, Alex, I'm so happy for you to say that. I don't like to be the only one, but no, I agree. And so, Alex was our student and then our fellow and now our colleague. And Alex and I yes, we really believe that it's a great thing to do. And then of course the sonographers too, Christy, I'm sure that you'd agree with this. I know that all the girls that work in our department that scan these patients regularly, they feel that the scan's not done until they've done that additional contribution that's made by doing CEUS.
And time for another question here, and this is a really good question. What is the average BMI of the patients that are seen for grayscale bowel ultrasound and bowel CEUS? The images shown today seem to be of people who are not overweight. I'm wondering what changes, if anything, when evaluating heavy patients. Thank you. I can definitely start with that. Actually, some of the images that you saw today were from patients with very high BMI. And so we have a few strategies that we do, including, I think you mentioned transvaginal ultrasound. We will also roll the patient onto their left side, for example, if we want to look at the terminal ileum in the right lower quadrant. And then we could still scan the bowel quite nicely and see it very well on some of the new probes that are the standard curvilinear probes. So we might change to those as well. And we have special probes that help us see a little bit deeper. But even if you don't have those probes, we're still very successful today of imaging patients with high BMI.
Just want to add that when we started, there is the thinking there that all the patients with Crohn's disease or IBD are very skinny. And we don't see this. Our patients are like regular average patients from like any clinic you're going to do any ultrasound of the abdomen. And we have the same challenges, but we have such a great sonographers, which are really strong. And actually they're doing a lot of compression and get those amazing pictures for us. So thank you.
Do we have time for one more question?
Well, we're not cut off yet, so
Yeah.
probably.
Okay.
Yes, let's do one more. Let's do one
Okay.
more.
Do you have any experience with contrast enhanced ultrasound involving endometriosis of the bowel or other pelvic structures?
Yeah, we do. So endometriosis, when we do our scans, we on some occasions know patients have endometriosis, and in other cases we don't. So in the patient that we don't know, actually endometriotic plaques, which form on the surface of the bowel, have a very characteristic appearance, like they liken themselves to what they're called plaques. And so they're often flat, they blend in with the serosal layer of the bowel, and they have on CEUS quite characteristic lower vascularity than we would expect, like for serosal seeds or anything like that. And then we can see endometriomas that are elsewhere in the pelvis, in the pouch of Douglas, and in the iliac fossas. And so we do encounter them as mass lesions. And of course, they have a differential. And the thing that most often comes into the differential is whether we're looking at peritoneal seeds, because it's the peritoneal surfaces of the bowel and adjacent organs that are involved with endometriosis. But so it can be quite helpful, I believe, and especially in patients who get, for example, have rectal bleeding with their menses. They can sometimes ask us if we can see evidence of involvement of the sigmoid colon, and we can often. It's an infrequent request, but when it happens, we often do see something.